for a long time, I've focused my career on managing mental illness, particularly mood disorders in pregnancy and the postpartum period. And in growing years with the epidemic of not only opiate abuse, but also other substance use disorders, have come to recognize that managing those problems during the childbearing years and pregnancy as well is a very common clinical problem that I encounter. And as the title of today's presentation implies, the comorbidity of mood disorders, anxiety disorders, and substance use disorders is something that we also encounter quite commonly in this context. And you see here my financial disclosure. This is these are actually my lifetime affiliations. In the past year, it's been limited to research support from Janssen and Takeda. And with that, the sections of today's talk, I'm actually going to start with an overview, which is we're going to talk about the magnitude of these issues, but also in particular, I'm going to up front give you your dessert rather than making you wait for it until the end by sharing with you some treatment guidelines that you can apply to different clinical contexts, because I think the guidelines will tend to be something that will remain relatively constant over time. What will evolve and change are the specific recommendations regarding particular diagnoses and particular medications and other agents that you might use as new information is forthcoming. We'll then talk about mechanisms for screening and identifying psychiatric disorders and substance use disorders in general, but in particular during the context of pregnancy, the concerns that these various illnesses convey to both mom, expectant mother, and her child, and then the treatment concern. What are the risks associated with different treatments that we might bring to bear? So with that in mind, we'll jump into the overview. I think all of us going through medical school training and social work or psychology are familiar with the notion that depression is twice as common in women as it is in men. But what we may not recognize is that higher vulnerability to depression in women is not evenly distributed across the lifespan. If you look at this particular graph, what you see is that prior to puberty, childhood depression is really no more common in little girls than it is in little boys, but at puberty, things change dramatically. And then if you look at the other end of the lifespan, after the menopausal transition, as you reach late life, women who have never had an episode of depression are actually less likely than men to experience new onset depression late in life. So this risk for depression in women clusters within the childbearing years, which I think we can draw two things from that. One is there must be or may be some role for changes in reproductive hormones playing some role, but it also conveys some treatment concerns, because just as women are entering their childbearing years, the vulnerability to depression begins to emerge. And sure enough, that's what we see. So this slide shares with us some information from a teratology information center in Montreal. You can think of a TIS center as a poison control center for pregnancy. In other words, someone has had or may be considering using some medication during pregnancy, and before they do it, they call in to check and see what might be the risks associated with this medication. And what you see is amongst different classes of medicines, most highly represented among the 23,000 plus calls that came in were antidepressants, and also very highly represented were calls regarding benzodiazepine and antipsychotic exposure. What the slide does not show you is that in the case of antibiotics and anti-inflammatories, the majority of the time when women or when providers called to request information regarding the safety or risk of these medicines in pregnancy, the medicine had not yet been taken. However, in the case of antidepressants, 80% of the time the women called or their providers called to check on the safety of the antidepressants in pregnancy, they had already been taking that antidepressant prior to the call coming in while pregnant. Similarly, with benzodiazepines and antipsychotics, the rates of exposure prior to the call coming in are around the 70 to 80% range. Similarly, addiction is a concern that arises just as women enter the childbearing years. As you see here, there's a huge spike in tobacco use, cannabis use, alcohol use, and if we had it graphed, I'm sure we would see similar things for opiate use and cocaine use spiking as girls enter their teen years, and then young women enter their early adult years, and you see that huge climb. Again, meaning this becomes an issue just as women enter their childbearing years. And unfortunately, the substance use continues on into pregnancy. 15% of teenagers, teen pregnancies, those girls will have some exposure to an illicit substance, most often alcohol. And if you'll notice the third column, what you see among teen drinkers when pregnant, the vast majority of them, when they do drink, it's binge alcohol use. And that's a particular concern because it's that binge pattern use of alcohol during pregnancy which has been most frequently associated with development of fetal alcohol syndrome. But even in older women, 18 to 25, half of those who use alcohol during pregnancy, of the 10% overall who have alcohol use during pregnancy, half of those are using in a binge pattern. And those from the 26 to 44 age range, 1/3 or more of those who have alcohol use are using it in a binge pattern. And you see a similar issue with cigarette use, where 1 in 5 women from age 15 to age 25 smoke cigarettes during gestation, and 10% of those even older are smoking cigarettes during gestation. I actually don't have this to share, the slide regarding this to share with you, but we recently evaluated some data from our own center here, and in which we collected information, self-report information, where the women told us whether or not they'd been smoking during pregnancy. And then we, late in pregnancy, did a urine screen to check for nicotine and a nicotine metabolite. And what we found was that a fair number of women who were not reporting to us or who were denying to us that they were smoking cigarettes were in fact still smoking. And most often, those who were being disingenuous or dishonest with us about having quit smoking were those who had planned pregnancies, who had told us prior to conception, I will quit as soon as I stop. Then they were often unable to, and then too ashamed, presumably, to share that information with us. And the increasing use of substances of abuse during pregnancy, as you might imagine, has a toll on infants. And what we've seen over the past 15 years is this epidemic, an astronomical increase in the rate of abstinence syndromes amongst neonates, most commonly, and this slide is sharing with you the impact of the opioid epidemic on neonatal well-being. And so how do we fit all of this together? Well, mental illnesses, mood disorders in particular, but also anxiety disorders, psychotic disorders, can have effects on the child's outcome, both acute effects, meaning that they can affect a child's well-being at delivery, they can affect fetal growth, they can affect increased risk for breathing problems at delivery, but they can also have developmental effects, so that children exposed to various mental disorders, children whose mothers experience episodes of various mood disorders during pregnancy are more likely than to exhibit certain developmental problems, including childhood anxiety, learning deficiencies, and so forth. And then mental illness, often people with mental illness are looking for relief. And unfortunately, sometimes they try to find that relief in substances that they use. And I'll share with you some data to that extent. And then the substances that they use feed back on the mental disorder, but then those substances also can have both acute and developmental risk for the baby. So then how do we treat these things? Well, we can treat them with psychotherapies, but we can also treat them with medications. And when these problems are more severe, both the substance use disorders and the mental disorders, very often it does require medications to effectively treat them. But as you see from this graph, the psychiatric medicines that we bring to bear in these situations can also have adverse consequences for a child. So in what way would it make any sense to use a psychiatric medication during gestation? And I would argue that the only reason that it makes sense to use a psychiatric medicine during pregnancy is if A, that medication can reduce the baby's level of exposure to the potential harmful effects of the mental disorder and or the harmful effects of the substance being abused, and B, that any risk attributable to that psychiatric medication are less than the risk of the mental disorder left untreated or the substance use disorder left untreated. And more about that as we go along. So what are the working assumptions? And these are kind of the summary points that I said tend to be unchanging over time. The first working assumption is if the mom is exposed, the baby is exposed. And what I mean by that is this: whether we're talking a psychiatric medicine or a substance of abuse, those medicines, in order to work, have to enter the maternal brain. And they have to therefore cross the maternal blood-brain barrier, which is a very difficult barrier to cross. Any substance that will cross that maternal blood-brain barrier, your working assumption should be that it will also cross the placenta. It will also cross the fetal blood-brain barrier. It will cross into breast milk, and it will cross the infant's blood-brain barrier. So if a pregnant or breastfeeding woman is taking a psychiatric medication, then your working assumption should be that that medication will also be not only in her baby's system, but in her baby's brain as well. Likewise, if she is using a substance of abuse, be it tobacco, marijuana, cocaine, alcohol, any other substance, your working assumption should be that that substance will not only be in the maternal brain, but will be in the baby's brain as well. The second point is that no medication is safe. And this is an important point from a clinical standpoint, because typically when patients will come to visit, their question, if they're trying to decide what they should do in terms of managing a mental illness, their question will often be, or will almost always be posed as, is it safe for me to take medication X? And you can fill in the blank with whatever medication that may be, from an antidepressant to an antipsychotic to, if we're managing neurological disorders, to anti-epileptic drugs, to antibiotics, so on and so forth. Their question is that medication safe? And my answer to that question is always no. You should not assume that that medication is safe, but you're asking the wrong question. And the reason I don't tell them that the medication is safe is because if I say yes, that medication is safe, what patients will infer from that yes is that this medication has been systematically studied, and every possible source of risk that it could convey to my baby, from birth defects to impacting fetal growth to increasing my risk for preterm birth, to having neurodevelopmental effects causing mental retardation or autism or motor development problems. They're going to assume if I say, yes, that medicine is safe, is that all of those concerns have been systematically studied and eliminated from consideration. And the reality is there is no medication that has been that extensively studied, in part because ethical guidelines understandably preclude us from doing randomized clinical trials. And so what we're left with are observational studies which have a highly variable degree of scientific rigor. Some produce very reliable data, others not so reliable. And so no medication, can we say, has a complete safety data across the entire risk spectrum. Therefore, we don't make that promise. What we do tell our patients is that there is a risk for using this medication, but there also may be risk from not using it, meaning if you leave the problem that the medicine is being used to treat untreated, then there may be some risk to that. And so what you come down to are situations where the same medication used for one disorder may be advisable during pregnancy because of the considerable risk of that disorder left untreated, when used to treat potentially another disorder may not be warranted. And we'll talk about that more as we go along. So how do we make clinical decisions? Well, the first point is to decide upon the primary objective. And this is something that I do in consultation with the mother in an effort to be patient-centered and empower her so that she feels an investment in the decision that's being made. One of the things that maternal fetal medicine specialists, our perinatologists, do is they try to avoid this concept of fetal maternal conflict. And the best way I can explain that to you is by way of an example. Some years ago, I had a patient who was pregnant and unfortunately developed cancer while she was pregnant. And so she was faced with a gut-wrenching decision. Does she go ahead and start chemotherapy, in which case it's a virtual certainty that she will miscarry, and even if she doesn't, conveys considerable risk to her child, as you might imagine, or does she postpone starting chemotherapy and potentially putting her own life in peril? So there's some situations where the interest of the mother and the interest of her baby do come in direct conflict, and that cannot be avoided. But very often that can be avoided. And the way we do that is when I am meeting with a patient, reviewing the risk and benefits, I do it considering the mom and the baby as a unit. What is best for you and your baby, and what are the risks for you and your baby? What are the risks for you and your baby if we leave your illness untreated? What are the risks for you and your baby if you continue this medicine? And so that we can at least help her avoid any unnecessary guilt or self-recrimination. She may still have some doubt about the decision that she makes, but at least she can know that she's making a decision with both her own, but more importantly, her baby's best interest in mind. And then as I shared with you on the previous slide, don't make false promises. In particular, I never tell a patient that a medication is safe, but I do often tell them that continuing to take that medicine or resuming that medication may be safer than the alternative of not taking it. The second thing then is, once we've decided upon the primary objective, is it to keep mom well? Is it to keep baby well? Is it to keep both well? And that's what I would argue for. Then we have to decide whether or not to use a medicine. Now, how do we decide that? Well, the first question is, what illness are we talking about, and can that illness be managed without medication? Certainly, there are illnesses like depression that can be managed in some cases without medication. If we look at the data outside of pregnancy, what we see is that mild depression, mild episodes of major depression often can be effectively managed with psychotherapy alone. Severe depression, there's compelling evidence that antidepressant medication or some other form of biological treatment needs to be brought to bear. Moderate levels of depression, the data can go either way, although again, moderate to severe depression, you tend to think medicines might be necessary. Similarly, with substance use disorders, we run into the same sort of issues. The severity of the illness, what particular substance we're talking about, as to whether or not it can be managed without some sort of medication intervention. Next, we want to know, how likely is it that the mental illness or the substance use disorder will recur or worsen if treatment is stopped? And I'm going to share with you some specific data with that as we go along, pertinent to various disorders. And then finally, we want to weigh the risk of the illness left untreated versus the risk of the medication. And let me share this example with you. As you know, we used to think some years ago that children outgrew attention deficit disorder. We now know that not to be the case. And so it's not at all uncommon to find a young woman with attention deficit disorder who decides to start a family or has an unplanned pregnancy and then must decide what she is going to do to manage her attention deficit disorder. When we look at the data regarding attention deficit disorder during pregnancy, what we see is no evidence whatsoever that attention deficit disorder left untreated during pregnancy conveys risk to any significant risk to either mom or her unborn child. Therefore, it's really very difficult to justify exposing mom and baby to a psychiatric medicine of any type to treat attention deficit disorder during pregnancy, because there is little or no risk of the illness. When we compare that to other disorders, so for example, someone with a seizure disorder, it's very clear that seizures during pregnancy convey significant risk to both mom and baby, and therefore it's much more easy to justify continuing an anti-epileptic treatment. And so what we have to look at then is, what are the risks of these conditions we're talking about? What are the risks of various substance use disorders left untreated during pregnancy? What is the risk of depression, bipolar disorder, anxiety disorders? And that becomes then the starting point to look at and compare to the medication. Then when we've decided that, finally, when we've decided that a medication should be used during gestation, we want to decide what medication would be best to use. First in that are the efficacy considerations. The basis for treating an illness during pregnancy, the sole basis is to protect mom and baby from the risk of that illness. Therefore, it makes no sense whatsoever to expose mom and baby to a treatment which is going to be ineffective. So how do we decide what treatment is going to be effective? Well, first, we want to know what are the indications for this given medication. And what comes into bear there are not only the primary diagnoses, but what comorbidities a patient may have. So if a patient has a mood disorder and a comorbid anxiety disorder, then we may want to be thinking about treatments that have an indication for both the anxiety and the mood disorder. Similarly, if a patient has a mood disorder and a substance use disorder. So for example, if a patient has depression and happens to have a nicotine habit and be nicotine dependent, then there might be a particular agent, namely bupropion, that we would want to use that would address both problems. But then we want to look at the patient's own treatment response history. What has worked well for her? So one of the things I invariably do when I'm doing a preconception or an early pregnancy evaluation is to review with the patient all of the psychotropic medications she's taken in the past and to get a sense of what has worked well for her. People often ask me, clinicians often ask me, what is the best medication to use for depression during pregnancy? There's two ways to answer that. If it's someone who has never been treated with a psychiatric medicine and has no first-degree relative who's been treated with a psychiatric medication, and therefore I have nothing to guide me as to what agent a particular individual might respond well to, then I will refer to what's the safety data tell me. And I will tell you, overall, the magnitude of the safety data when we take both pregnancy and the postpartum period into account is probably greater for sertraline than any other. And so very often I and most clinicians, I think, will prefer sertraline during pregnancy. But if I have a patient come in to see me who has taken sertraline before and found it to be either poorly tolerated or ineffective, just because she's pregnant is not reason for me to switch her back to that agent which we know from her own past experience was either ineffective or did not, or she could not tolerate well. So we want to know that history from her own. And then finally, in terms of efficacy, it's important that we avoid subtherapeutic dosing. And this is a clinical issue that often arises when a patient has an unplanned pregnancy. She calls her clinician who shares her anxiety regarding, oh my goodness, you're pregnant while taking this medicine. Well, we can't stop the medicine. What should we do? I know, let's reduce your dose. The problem with that is that if she got to that dose that she was taking prior to pregnancy because lower doses had not been as effective, then she probably needs that dose that she was taking when she became pregnant. By reducing the dose, but not stopping the medicine, what the clinician is doing is continuing to expose the baby to the medication, and so the risk of the medicine continues. But now, because the dosing is subtherapeutic, not adequately protecting mom and baby from the risk of the illness. And so in my mind, ineffective or subtherapeutic dosing of a medication is the worst of all possible worlds for mom and baby alike, in that both are exposed to the risk of the medication exposure, but also we're increasing the risk of the illness because of ineffective treatment. And then the safety considerations. Well, this is where you want to look to the reproductive safety data. What are the safety data tell us about use in early pregnancy? What does the safety data tell us about use in late pregnancy as delivery approaches? And what is the safety data for use of this medication in breastfeeding? This is the part where you're going to have reference books handy. I'll certainly share with you current date on that, but in the space of just every few years, this dramatically changes. You also want to know about prior fetal exposure. So when it comes to efficacy, we're looking at prior treatment response. When it becomes to safety, we want to look at prior fetal exposures. One of the things that I want to do, and I think you will want to do, is avoid exposing a baby to any more medicines than is absolutely necessary. So when you decide to use a medicine, use the dose adequately, so don't be shy with the dose, but try to keep the list as short as possible of the number of medicines to which a baby has been exposed. It's difficult enough to find reliable data on one medicine or two medicines, but when we start shifting medicines, then what we end up with is something where we have serial exposure to a variety of medicines, and it's next to impossible to predict what effect that might have on the child's development or obstetrical outcomes. And so when I have a patient come in, and this is the scenario where you very often encounter this, an unplanned pregnancy, she stops her medication in a well-meaning effort to see if she can avoid exposing the baby, but then she experiences a relapse of her disorder. Now she's ill, her illness is sufficiently severe that we have to make a decision about treatment, and we decide that resuming treatment is probably safer for her and the baby than leaving her severe illness untreated. What treatment are we going to go to? If she was taking a medicine that had been effective and the baby has already been exposed to it, then generally speaking, it's going to be much wiser to resume that medication unless there's still some particular risk with that medicine that we can avoid. It's generally better to resume that medicine rather than switch her to an alternative. And the reason I say that is, if we switch at that point to an alternative medicine to which she's not taken before, then what we're doing is not only increasing the number of medicines to which the baby's been exposed, but because we're switching her to a medicine that may not work as well as the medicine which she was previously taking, we're actually increasing the likelihood that she remains ill longer, and therefore we are increasing the baby and the mother's duration of exposure to the risks associated with an illness. And then finally, we want to avoid exacerbating any existing obstetrical or medical complications or risks. So for example, if a patient has a history of gestational diabetes, we certainly want to avoid those agents, if possible, that are known to carry a heightened risk for metabolic syndrome, because we know that may increase their risk for gestational diabetes in this new pregnancy. Another example, if we have a patient who in a prior pregnancy has developed preeclampsia, in which she was at risk for seizure during that pregnancy, we want to avoid, if possible, agents that might increase the risk for seizure, namely bupropion, if she should develop preeclampsia again in this pregnancy. So those are all things that will help you to decide first whether to use a medication, and will help guide you to what medication you should use. Very often what I find is that once I've gone through these steps, then I find that the decision becomes very simple as to what medicine to use. The more challenging decision is whether or not the medicine should be used. And so now let's talk about some of the issues in terms of identifying these conditions during the course of pregnancy. So diagnosing depression during pregnancy. What you see here on the left is a listing of the 9 cardinal symptoms of a major depressive episode according to DSM criteria. And in this particular study, now about 15 years old, of 159 individuals who were diagnosed with depression while pregnant, what you see is that only 3 of those symptoms, namely anhedonia, sleep change, and fatigue, were present in 50% or more of the people. In fact, depressed mood was only present in a little bit less than half the people. But here's where it becomes challenging. Of those 9 symptoms, it's possible to argue that 5 of those symptoms, appetite or weight changes, sleep change, fatigue, psychomotor changes, difficulties with concentration, may be attributable not to depression, but to pregnancy itself. Now, this has been an issue that's not unique to pregnancy, but it's been an issue that comes up anytime someone has or is at concern for, at risk for having depression in the context of some other medical condition. Where we first discussed this 25 years ago or more was depression in cancer patients. If you go back to the late 80s and early 90s, there was a debate in the literature about whether or not or how reliably you could diagnose depression in a cancer patient. And the argument was made, well, of course they have weight changes. They have cancer cachexia. Well, of course they're thinking about death. They have cancer. Well, of course they're tired. They're getting chemotherapy. And so if you start ticking off those symptoms that might be due to the cancer or might be due to some of the treatment for the cancer and don't count them towards the diagnosis of depression, then it becomes more difficult to manage depression, which it may be appropriate if we want to maximize our specificity for diagnosing depression. And it became that, a tug of war between should we maximize our sensitivity or specificity. What won the day was when the data began to emerge that showed that cancer patients, first with breast cancer and then later with head and neck and other cancers, when the data began to emerge that demonstrated that depressed cancer patients, if their depression was left untreated, were less compliant with their oncologic care, but also had a poorer quality of life and shorter survival times. And so in the context of cancer, what began to emerge and now has become a standard of care is that we want to maximize our sensitivity for diagnosing depression in those cancer patients to make sure that everyone gets treated. Yes, there may be some who are unnecessarily exposed to antidepressants, but the price of that is very small compared to the price of leaving depression untreated. When we apply that same debate to pregnancy and depression, we still haven't reached a consensus. And the reason is because there are remaining concerns regarding leaving depression untreated during pregnancy, but there are also concerns regarding the risk of exposing a fetus in particular, but also a pregnant woman to these psychiatric medications. And so I leave it to you to process this data and decide clinically from your standpoint, which one do you think you need to be maximizing, your sensitivity for diagnosing depression or your specificity? And at present, we don't yet have an overall consensus to that. Because of that, we used a particular approach in this study. So this is a study I participated in some years ago where we wanted to evaluate the performance of different depression rating scales during pregnancy. And we looked at the Beck Depression Inventory and the Edinburgh Postnatal Depression Scale, two self-rated instruments, as well as the Hamilton Rating Scale for depression. And because we weren't sure still whether we should maximize sensitivity or specificity, what we did in the study is try to find a cut point for diagnosing or identifying depression that maximized the sum of the two. And what we found was that among those scales, the one that was most sensitive for identifying depression was in fact the Beck Depression Inventory. And yet the one that was most reliable and consistent across the different trimesters was the Hamilton rated scale for depression, in which case, if you notice, the cut points of 14, 15, 16 are very tight. And so as you move from one trimester to another, those things don't tend to change very much. Among those scales, I think, in clinical use, most of you are going to want to prefer using a self-report instrument. And so the Hamilton would be eliminated on that basis. I do find, the Edinburgh, while it's widely used for postpartum screening, one of the problems with it is some of the items are reverse scored in it. So it's very difficult to quickly look at it and add the score up because of the complicated scoring. The Beck Depression Inventory, the Montgomery-Åsberg, the variety of instruments that can be used, and I think those can be very helpful for helping you to not only identify depression, but also to track the course of depression during pregnancy and through the postpartum period. Screening for substance use disorders is also very important to do during pregnancy, and I want to share with you, for those of you who may not be familiar with it, SBIRT, which is emerged from collaboration from SAMHSA and the Health Resources and Services Administration in response to an Institute of Medicine recommendation for community-based screening for health risk behaviors, including substance use. in a variety of clinical settings. And so SBIRT, the acronym stands for Screening, Assessing Patients for Risky Substance Use Behaviors Using These Instruments in Any Clinical Setting, Brief Intervention, where the person who's performing the screening can do a brief in-office intervention, and then finally referral to treatment for those who have identified a very significant problem moving forward. And it's possible to take this approach and implement it in the context of family planning and childbearing. So how does an SBIRT decision tree work? Well, NIAAA and the National Institute of Drug Abuse have both recommended a single one-question pre-screener. So it's a matter to screen for alcohol use problems, to screen for drug abuse problems. Per their recommendation, only requires you to ask one question. If they meet the threshold for that, then there are a couple of instruments that are recommended: the audit for screening, questionnaire for screening for alcohol use, the DASH for screening for problematic substance abuse, and then depending upon the results you get on that, will guide you to, at the bottom level of this slide, what intervention. So on the audit scale, if the alcohol score, and there are 10 items, just so you know, each scored 0 to 4. If the composite score is between 0 and 7, or on the drug abuse scale, which is 10 questions, each scored 1.0 or 1. If they score in the low to no risk range, basically there's no intervention necessary. You just tell them, good work, keep doing what you're doing. If there's an at-risk pattern based upon the scores, then that's where a brief intervention comes into play. And your goal there is to help them lower their risk of substance use and reduce it to acceptable levels. Now, in the context of pregnancy, acceptable levels would generally be none at all. Moderate to high risk and high severe risk, when they hit those thresholds, that's where you want to come in with a brief in-office intervention, but also not perhaps, but preferably make a referral to a treatment center. And so the pre-screening questions. For alcohol abuse, the one-item alcohol pre-screener question is, how many times in the past year have you had 4 or more drinks in a day? Now, and 4 or more drinks is the number you use for women. For men, it's 5. And if they answer 1 or more in the past year, that's considered a positive screen. The drug abuse pre-screener from NIDA is, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? And again, you see the positive screen is more than once in the past year. And then once you get through the pre-screener question, then you have a variety of instruments that you can use. We're going to focus on the audit and the DAST. You see the variety of these assessments for alcohol, some for drugs, different patient populations, adults, teens. The TWEAK is for pregnant women, and as you see, some are self-report, some are interview, and some are even available in a computerized format. In the audit, the 10 question screening, again, each item has a 0 to 4 scale on a Likert scale. How often do you have an alcohol-containing drink? How many drinks do you have on a typical day? How often do you have 6 or more? So on and so forth. And again, how often during the last year have you needed a first drink in the morning? How often have you had a feeling of guilt after drinking? And then you see those additional questions there. The total score, the maximum score, I should say, is 40 points. 0 to 7 is considered low risk. 8 to 15, I believe, is the range, is considered moderate risk. Beyond that is high risk. The TWEAK is an alcohol screener developed for pregnancy, and a positive screen is a score of 2 or greater. And you see they ask about, you ask about tolerance, worry about drinking eye openers, amnesia, which is blackouts, or cutting down. And 2 or more on that is considered a positive screen during pregnancy. The drug screening, again, is another 10-question questionnaire, and these are answered yes, no, so each one is scored 0 to 1. Have you used drugs other than those required for medical reasons? Do you use more than one at a time? Are you always able to stop? Have you had blackouts or flashbacks? Do you ever feel bad or guilty? Does your spouse or parent ever complain? Have you neglected your family? And you see the other questions. A negative screen on that one is 0. Anything above a 0 raises some cause for concern. Now, you can also use laboratory tests to help you with screening, at least with alcohol. And the tests you see here include the carbohydrate deficient transferrin, the transaminases, ALT and AST, gamma glutamyl transferase, and mean corpuscular volume. And each of these, you see the time to elevation, so how long they have to be drinking at a problematic level for it to be detectable with that test, how long, the time to normalize, how long they have to have been abstinent for that test result to return to normal, alcohol dose response, how much do they need to be drinking each day, and then you get to sensitivity. And what you see there are those sensitivity issues with those individual tests are just not very good. 55 to 90% for the CDT, which is as good as any of them. Specificity, a little bit better for the CDT, a little better for AST-ALT ratio 2-to-1, but overall, those sensitivity and specificity numbers are not great for screening tests. But what Spiegel et al. In this study shared with us is that if we combine those tests, then we may be able to dramatically increase our sensitivity. And personally, if you come down to the fourth row there, the mean corpuscular volume and the transaminase AST over ALT ratios, I have really come to be in favor of those, because typically when you're doing laboratory evaluation on these patients, you're going to get a complete blood count and a comprehensive metabolic screen, which already includes those, and you don't really appreciably improve your sensitivity by adding on these other more expensive tests, namely the GGT and the CDT. So if you have a mean corpuscular volume greater than 100 and AST-ALT elevation in that classic 2-to-1 ratio, that's 95 to 97% sensitive for a problematic level of alcohol use. Now, in the brief intervention itself, what should your approach be? Well, part of what you have to do is recognize where the patient is in this process. Often they may be in a pre-contemplation phase. Not recognizing that they have a problem. And your goal there should be to show empathy with them, build a therapeutic alliance, and namely to raise doubt, to begin to get them to consider the possibility that, you know what, there may be an issue here and maybe I need to do something about it. Hopefully then you can move them to contemplation, bringing them to a point where they have some ambivalence about what's going on, invoking reasons for change, sharing success stories, with your other patients that you've seen. Once you get them beyond that to determination, helping them to get to that point, then you want to help them devise a course of action and then help them move forward in that action. And then finally, I want to bring your attention to that last row, recurrence. Recurrence does sometimes happen. Let me rephrase that. It does often happen. And there's nothing to be gained by ridiculing or shaming a person who has had a recurrence. It is important, however, to help them to learn from that. And so part of what I will do with a patient who has had a relapse or had a recurrence of a substance use disorder is to help them alleviate the guilt. And there's no value to you or to anyone else in beating yourself up over this, but it is important to learn from it. Knowing now what you know, if you had the opportunity to go back in time, what would you do differently so that they can learn from that and apply that going forward? It is natural that they're going to be ambivalent, and so you can help them explore that. What are the good things about smoking cigarettes? What are the good things about drinking alcohol? What are the not so good things about it? What are the good things about changing what you're doing, and what are the not so good things about it? The fact of the matter is, using substances does provide something positive. Otherwise, people wouldn't do it. And so there is going to be some mixed feelings they're going to have about that. Help them to explore that, acknowledge it, and let them know that this is appropriate, that you might have some mixed feelings about it. So let's talk about the concerns with the illness. When we talk about mood disorders and depression, one of the things we find is that when people stop taking antidepressants, they are at risk for relapse, as you might imagine. So this particular slide shares with us data from a study that I participated in over a decade ago, in which we took a little bit over 200 women This was not a randomized clinical trial. These were women who made their own decision. They were euthymic at or about conception. They were taking an antidepressant, and they had a decision to make. Do I keep taking my antidepressant? Do I stop it? And what we found was that those who discontinued their antidepressant, shown by the green line there, nearly 3/4 of them had a relapse prior to delivery, and half of them had relapsed quite early on by week 16 of pregnancy. Whereas those who maintained their antidepressant during pregnancy, about 75 to 80% of them were able to remain well. Not all, but the majority. If we look at a similar graph for bipolar disorder, what we see is among patients with bipolar disorder who stopped taking their medication, 85% of them will relapse prior to delivery. Alcohol and substance use disorders among young people, the more people are depressed, the more likely they are to use other substances. And we see this among teens, as shown here. So the rate of alcohol use and drug use is 3 to 5 times higher among teens who are depressed. And the same thing applies to young adults. Those with no mental illness have rates of use of drugs overall, marijuana, other things, at about half the rate of those who have any sort of mental disorder. Pregnancy does not change this. And so what these slides begin to show you is that the more depressed that women are during pregnancy, the more alcohol they drink, the more cigarettes they smoke. And what we found in this study is the severity of their depression associates directly with the frequency with which they will use a sleep medication, an anti-nausea medicine, an opioid pain reliever, or tobacco. Similarly, the severity or the level of their anxiety during pregnancy predicts the frequency of which they use benzodiazepines, sleep agents, and tobacco. People who are anxious and depressed are suffering, and they're looking for relief. And so sometimes when you're deciding about a treatment offering, part of the risk that you're weighing is what other exposures might be conveyed in their effort to use illicit substances or over-the-counter things or other prescription narcotics and the like in effort to get some relief. So what are the consequences of prenatal depression and anxiety? Here's a beginning list. Gestational hypertension, preeclampsia, preterm birth, low birth weight. Depressed patients are much more likely to require an operative delivery or have a baby admitted to the NICU, and their children, dozens of studies have shown adverse developmental consequences for children whose mothers were depressed or anxious during pregnancy. Among those developmental consequences are adult cardiovascular disease, type 2 diabetes, osteoporosis, schizophrenia, and depression amongst the offspring of women who have significant levels of stress during pregnancy. What are the concerns regarding substance use? Well, this is just a summary of the NIDA advisories. In terms of acute outcomes that we're worried about, tobacco, as you see here, preterm birth, low birth weight, low birth length, lower head circumference. Similar things with marijuana, including a risk for stillbirth. Cocaine, the list are quite considerable, with the notable addition of prenatal hypertension and placental abruption. Similar pattern, as you might imagine, with methamphetamine, with heroin and opioids, stillbirth, preterm birth, and then this really problematic neonatal withdrawal syndrome. Developmentally, as we move beyond the neonatal period, children exposed to tobacco and heroin in utero are at greater risk for SIDS. Tobacco, you see learning problems, behavioral problems, and interestingly, childhood obesity, methamphetamine, attention deficits, behavioral problems, and the like. So the illnesses certainly pose cause for concern. What about the treatments? Well, if we could, we would want to avoid using psychotropic treatments and exposing babies. But as you see, the antidepressants, at least when the depression is more severe, may be more effective than the psychotherapy. Although I'll point to that second bar from the left to illustrate the point that antidepressants and behavioral therapy in combination, you get a synergy that works better than either by itself. So I routinely advise all my pregnant patients to please pursue psychotherapy if they can, and ideally a good short-term therapy. Now, as I mentioned before, all psychiatric medications cross the placenta. And what you see in this graph is the level in the children relative to the level in the mom. So that horizontal blue dashed line, that's the 100% level. Anything above that, the level of the medicine is actually higher in the baby than the mom. If you look at the far right, that's venlafaxine. Venlafaxine is often at higher levels in babies and mom, and that may be understandable. It's not very tightly protein bound. It's a smaller molecule, so it quite likely more readily crosses the placenta. If we move to the middle in that orange circle, that's paroxetine. And here's the interesting thing. Paroxetine crosses the placenta less than the other antidepressants that have been studied, and yet it's the only one amongst those in this slide that has a pregnancy category D designation. And so we do want to expose a baby to less medicine, but just because a baby is being exposed to less medicine doesn't in and of itself mean that medication is safer. Paroxetine has that D designation because of concerns regarding heart defects in the offspring. But because it was the one that was transferred at the lowest rate, we decided to use it in this animal study. This is a study in rats. We wanted to see how much of this medicine actually gets into the offspring brain. Well, obviously, that's not a study we can conduct in humans. And what we found was in this study, well, let me give you the approach we used. We took pregnant rats and we implanted a subcutaneous mini pump to continuously deliver paroxetine. And we were trying to deliver it at a level that approximated the daily dose that a human might take. And so we did a low dose comparable to about, we were aiming for about 30 milligrams per day, and then a high dose aiming for about 40 milligrams a day. And what we found was that at either dose range, 98% of the serotonin transporters were occupied in the brains of, this is not the mom's brains, but in the brains of the rat pups, illustrating the point that when these medicines are administered in pregnancy, they are getting into the brains of the offspring at very high levels. In terms of birth defect data, overall, the data has been quite reassuring. The rate of birth defects in this country, about the best estimate we have is from New York, is about 4% malformations, 3.5% in the Swedish registry, and you see the rates among overall medicines being very comparable. A very recent meta-analysis published in JAMA showed no evidence of increased risk for overall birth defects with antidepressants, but there was some concern raised for cardiovascular defects, particularly with paroxetine, as I mentioned earlier. In terms of preterm birth, this is a study that we're submitting for publication now, and this is the kind of work that I think needs to be more forthcoming, where we're looking at the same time both at the effects of medication exposure and at the effects of illness exposure, controlling one for another. And if we start at the bottom here, what you see is that antidepressant exposure during pregnancy is associated with a higher risk for preterm delivery, an odds ratio of 2.31. But we also see that with a moderate level of depression, a comparable level of increase in preterm delivery. And so at that point, in terms of deciding whether or not to treat, at least with regard to the preterm birth rate, it's pretty much a wash. But then if you jump to the top of this table with severe depression, which we operationalized as a Hamilton Depression Rating Scale in the third trimester of 21 or greater, what we found was those women controlling for antidepressant exposure and other of these things like placental abruption and maternal infection, those women were at 9 times higher rate for preterm delivery. And so we end up at a point where those with severe depression, while antidepressant exposure will not return their risk for preterm delivery back to baseline levels, it may, on a net basis, provide some degree of protection from preterm birth, at least among those severely depressed women. Neonatal adaptation, you see a variety of issues there. And the key thing that's been focused upon is the concern of persistent pulmonary hypertension of the newborn, which is a serious complication among newborn babies. The first report came out, green bar shows you it was positive. The FDA put out a warning. And then we've seen mostly since then negative studies, so that in December 2011, the FDA rescinded that warning. As it stands right now, despite the fact that we often see label warnings about third trimester SSRI use, it does appear that children exposed to SSRIs are at heightened risk for mild transient withdrawal problems or symptoms, but there is not compelling evidence that they're at heightened risk for PPHN. Neurodevelopmentally, things had looked very reassuring, the only outlier being this Casper study, which was problematic in that 29% of the children were enrolled after delivery. Mental developmental indexes, which you can think of as IQ scores, never any difference shown between those exposed to antidepressants and those not. The only difference being shown in a fine motor skills in that Casper study, whereas the others were all perfectly normal. Most recently, the thing that's come up is concern about autism in children exposed to antidepressants. And what we've seen there is most of the studies have been negative. When I performed this meta-analysis a few months ago, it still came up slightly positive. I haven't produced a slide for it yet, but there's since this time been 2 more studies were published in JAMA within the last 6 weeks, and now that finding is no longer significant. Where we stand with antidepressant exposure and autism is there is no compelling evidence that antidepressant exposure increases risk for autism. In fact, 2 of the more recent studies have indicated that it may in fact be maternal depression that may convey some risk for autism in the offspring. In terms of substance abuse treatment, swinging the pendulum back there, we have a variety of behavioral therapies, 12-step therapies, but then we also have pharmacotherapies. And this is a summary of the different treatment approaches. In the interest of time, though, I want to move on to the safety data. And what we see is not a lot of information, unfortunately. And so the FDA pregnancy categories, either no rating, C ratings, or the D rating for topiramate. But when you dig a little deeper, and I'm sharing with you here the human and animal data from the Briggs and Freeman text, which is a standard text for understanding safety data in gestation, what you see is limited data, limited data, limited data. There's very little reassurance offered by this. Interestingly, the one thing that in the Briggs and Freeman data that's rated as compatible is actually nicotine replacement therapy, but considerable concern there. Is it advisable to detox opiates during pregnancy? And this has been a bone of contention. Should patients who have heroin addiction and addiction to other opiates, should they be maintained on methadone or should they be detoxed? Well, one of the problems with the detox is what effect does the detox itself have on the fetus, which this slide does not address. But what it does address is their potential outcomes if they do not remain abstinent. And in this particular study of 93 women, what you found is that nearly half of them who were detoxed off, despite knowing they were pregnant, relapsed and used. And amongst those who relapsed, you see 80% of them had babies who were treated for neonatal abstinence, remaining in the hospital for 22 days versus 3 amongst those who remained well. And a tremendous cause for concern. If they're going to be maintained, what should they be maintained on? Methadone, buprenorphine, or Subutex. There are pros and cons there. With methadone, they tend to be more likely able to remain abstinent than they are with methadone. And so if you look at those urine drug screen rates, the likelihood of being positive for cocaine and opiates is about twice as high with those who are taking buprenorphine as those taking methadone, and the benzodiazepine exposure is several times higher. But among those who are on buprenorphine, they do tend to have much shorter hospitalization days, even accounting for the fact that they may be using other substances, looking at that length of hospitalization. Lactation safety data, again, very limited. It's reassuring that very little buprenorphine crosses into breast milk and gets exposed to the baby. Similarly, low levels of methadone get into breast milk. And the American College of OBGYNs has actually recommended that breastfeeding while taking an opiate agonist, namely methadone, or partial agonist, namely buprenorphine, combined with swaddling may decrease symptoms of neonatal abstinence syndrome. And so our colleagues in obstetrics and gynecology have actually recommended using medicines of this sort to diminish those withdrawal symptoms in the neonate. And with that, I want to say thank you. I realize I've used all the time and not left time for questions, but I am available to stay a little bit longer for those of you who may have some questions.
All right, let me read this for you. If a pregnant woman with several mental health conditions such as schizophrenia refuses medication and has a history of harming herself when not taking meds, what is your course of action? I'm sorry, so, severe mental health condition.
Yeah, well, I think in a case like that, you know, we have to be guided by the same legal concerns or legal guidelines that we apply outside of pregnancy, which is in order, you know, we're guided by what is the risk? Is the risk imminent? And so we have to be guided by that. And so if we take pregnancy out of the equation, we know that patients with schizophrenia are very often non-compliant with treatment, and that made them put them at risk for certain behaviors. And yet we cannot force treatment or impose treatment upon them, you know, without taking certain legal steps. Pregnancy does not change that. And part of the reason pregnancy does not change that is in most states, at least, and including Florida, to my knowledge, the unborn child does not yet have a legal standing. And so we have to, that's just a reality that we have to deal with. Now, postpartum, that certainly becomes a condition where, you know, intervening to protect the baby on the basis of noncompliance with care, then putting the baby at risk is, you know, the pendulum then swings in terms of being proactive and taking steps to protect that child.
Is there any new findings as to the apparent increased incidence of autism?
So again, and I assume that question came up before I address this. So the very first of the autism studies, I think, illustrates a key point. And of the 4 or 5 studies that were positive, the one that by far had the highest odds ratio was the very first one, and had an odds ratio for 3.5, meaning they were estimating that women who took antidepressants during pregnancy were 3.5 times more likely to have a child with autism. And I'll preface this by saying I personally have a child with autism, so this is an issue that's very important to me personally. In that particular study, it was a insurance company study, and the researchers never laid eyes on the children. They worked off 2 clinical databases, a pediatric diagnosis database and a prescription database. And so they went first to the pediatric diagnostic database, found kids in this insurance plan who had been diagnosed with autism and those who had not. Then they linked that up with the prescription database to identify which of those children their mothers had been prescribed antidepressants during pregnancy and which had not. And then lo and behold, they saw this 3.5 times higher rate for antidepressant exposure amongst the children with autism. That was not the only difference between the kids. The kids with autism not only had mothers who were more likely to be prescribed an antidepressant, but their mothers were more likely to have a college education, and the mothers were more likely to be Caucasian non-minority. Now, what is it about being Caucasian, non-minority, and college educated that makes a child more likely to have autism? People have looked at that, and the answer is nothing, but it does mean that you may be more likely to have the resources to have a good, thorough evaluation and an adequate diagnosis. And so what we had in that study was clear evidence of a surveillance bias. And that's one of the problems that we get into. Some of the more recent studies, including the 2 studies that came out in a very recent issue of JAMA 6 to 8 weeks ago, were much better designed studies using much more reliable data gathering techniques. And if you remember one of the first slides I shared with you, I alluded to the fact that to in this field, we rely upon data from observational studies, which has very widely discrepant levels of data reliability. And these more reliable studies that have come forth more recently have actually not shown evidence of increased risk for autism. So I think where we stand now is that the data is certainly indicating that, at least in my mind, that antidepressant exposure is not increasing the risk for autism.
Oh, and please forgive me if I pronounce this word correctly. Can you comment on a woman stabilized on a carbamazepine for epilepsy who now becomes pregnant?
Okay. So carbamazepine is associated with a variety of problems in pregnancy. One, it can increase the risk for neural tube defects or spina bifida by about from 0.5% to maybe as high as 1%. But now, if the patient in question is already pregnant, the neural tube closes at week 4. By the time she recognizes she's pregnant, that will have already happened. And so if she's already pregnant, it makes no sense to stop the carbamazepine in order to protect her baby from having spina bifida, because it will have already happened. Now, there were other studies that initially that raised concern that carbamazepine might also increase the risk for mental retardation in the offspring. That would be something that you might be able to still protect the baby from, but actually more recent studies, including the NEED study, Neural Developmental Effects of Anti-Epileptic Drugs, indicated that was not the case. So here's what I would do in the case of carbamazepine used to manage a seizure disorder. If the patient is already pregnant, leaving her seizure disorder untreated is a non-starter. Switching her to another medication, it's probably too late to offer the baby any protection. But the one thing you should do, if you haven't already, is make a point to have the baby on a high-dose folic acid supplement of about 3 to 4 milligrams per day that may provide some additional protection. Now, if the patient comes to you and is planning to conceive, she's not yet pregnant, then it's probably wise to have a discussion with her, postponing her efforts to conceive in an effort to perhaps find an anticonvulsant, be it levetiracetam, lamotrigine immediately come to mind, as agents that might manage her seizure disorder that would provide some improved safety. And so whether this gets back to the issue I was sharing earlier, where you encounter her, be it preconception or already pregnant, may change the advice that you give her.
Unless you have any other parting comments, we're gonna conclude our broadcast.
Okay. No, thank you very much. It was a pleasure doing this with you all.